next set of discussion is important in the sense that you're going to be dealing with blood gases for the rest of your career. So you have to start understanding how acid bases are an important part of that test. The first thing you want to look at when you're doing a blood gas is to actually look at the arterial pH. And the normal range should be between 7.35 to 7.45. So the actual normal value you're looking for is around 7.40. That's your normal pH. Okay? If you see this number fall, 7.30, okay, and then that person is acidotic. If you see it rise to 7.45 and greater, then that person is alkalotic. Okay? Usually an acidosis is due to an increase in hydrogen ion concentrations. It could be due to other reasons such as lactic acidosis and other inorganic acids, non-volatile acids. So it can be other sources of acidosis, but most of the time you're looking at just increases in hydrogen ion concentrations. Now there's 4 categories of acid-base balances, and this is what we're going to test you on. Okay? And you have to differentiate between respiratory and metabolic. Okay? You have respiratory acidosis or alkalosis, and then you have metabolic acidosis or alkalosis. Respiratory acidosis has to do with volatile acids, okay, which in this other words has to do with CO2. Okay? So anytime you get an increase in CO2 production, this will eventually lead to increases in hydrogen ion concentration and lead to a respiratory acidosis. Okay? So the most common cause of respiratory acidosis is when the minute ventilation is not adequate to the CO2 production. Okay, so a person who's sedated, say, and their minute ventilation drops off, and the CO2 levels, even though they're continuously being made at the same rate, now they're beginning to accumulate, and that person will develop acidosis as a consequence. On the other hand, if you see a respiratory alkalosis, it's a depression of CO2 production due to alveolar hyperventilation. So it has to do with the volatile acid, which is CO2. For metabolic acidosis, it could be due to depression of bicarb production or an increase in the non-carbonic acids, so known as non-volatile acids. A typical example of metabolic acidosis is things like lactic acidosis. There's also poisons that you can take in that can also induce a metabolic acidosis. Okay? Ethylene glycol will cause the same thing. Okay? So metabolic alkalosis, on the other hand, is an elevation either in bicarb, which is usually due to excessive loss of metabolic acids. Now let's go into the first one, respiratory acidosis. Okay? The most common cause of respiratory acidosis is decreased minute ventilation. Okay? Specifically, minute ventilation. Okay? Why minute ventilation? Because minute ventilation is respiratory rate times tidal volume. Okay, so if respiratory rate drops off, and minute ventilation falls, that person will develop a respiratory acidosis. If you're unable to clear the CO2 begins to accumulate in the bloodstream, and as a consequence forms the reaction as follows: CO2 plus water. Okay, it shifts the reaction this way, form H2CO3, which is carbonic acid, which then forms the hydrogen ion plus bicarb. It's ultimately this production of hydrogen ion which leads to the respiratory acidosis. Okay? All right. Now, what happens as a consequence to respiratory acidosis is that you do have a compensatory organ still left, which is the kidney. The kidney will immediately begin to excrete high concentrations of hydrogen ions in the urine, which in other words, the urine will acidify, and bicarb will then be reuptaken from the kidney as well. Okay, so it tries to do it 2 ways. It can do it by acid binding to the ammonia, or it can bind to the phosphate groups to cause this loss of very acidified urine. So the amount of acid being excreted in the urine increases, and the amount of bicarb being generated by the kidneys also increased in the consequence. This eventually leads to a resumption of an increase in serum pH, but it really never does it fully unless you have a good reversal of the respiratory acidosis, so respiratory ventilation. On the other hand, respiratory alkalosis, which is something that we do frequently in the operating room, because we tend to increase our minute ventilation excessively, okay, we will cause a drop in the arterial CO2 value. This leads to a conversion of the CO2 from water, and it pulls the hydrogen ions, and it basically causes a decrease in hydrogen ion concentration, which leads to an increase in pH. The kidney will compensate this over this next 6 hours by decreasing acid loss, so it begins, it leads to an increase in hydrogen ion, decrease in hydrogen ion loss, and an increase in bicarb loss in the actual urine. So the actual acid excreted in the urine drops off, and the urine begins to actually appear to be more alkaline in nature. Eventually, it'll lead to a decrease in serum pH, which tries to neutralize the pH back to 7.40. Compensatory takes a long time, 6 to 18 hours to see that effect. So that's not something you'd normally see. Now, the metabolic acidosis is an anion gap. There's two kinds of acidosis, an anion gap and non-anion gap. And what that basically means is you actually can figure out, looking at the electrolytes, if you have an excessive amounts of extra molecules that are sitting around that are causing the metabolic acidosis. Okay? The normal anion gap is due to bicarb loss. Okay? So when you look at the anion gap, it's basically an equation where you have the number of sodium molecules plus the number of potassium molecules minus the bicarb. Okay? If you have your normal anion gap that takes place, it's usually due to loss of bicarb. Okay? And things like that were caused by diarrhea and other things like that. Versus if you have an abnormal anion gap, it's usually due to an increased level of abnormally unmeasured anions. Okay? Things that will do this will be like poisonings, okay, such as salicylate poisoning, situations with like lactic acidosis, okay, which is a very common cause, and things like diabetic ketoacidosis. Okay? It also indicates to you that you have decreased hydrogen excretion, and may also indicate that you have a uremic patient, which means that they're in renal failure. Yes? Mm-hmm. Sometimes it's included depending on which book you use. A lot of us don't use it, but some people do. Okay, so I'll get back into that at a later time. We'll talk about anion gap another time. Anyways, I just want you to know that there's differences. The one that you have to worry about, most of the anion gaps are significant of the ones that are the poisonings, and the lactic acidosis is ones that you have to worry about. And what ends up happening is you begin to lose your base, okay, so you get bicarb loss. This leads to a drop in your serum pH. The body tries to compensatorily try to hyperventilate to remove CO2, which then eventually leads to a decrease in hydrogen ion production, which hopefully will neutralize the pH. It never does it fully, but it does a fairly good job of doing it pretty quickly. What ends up doing most of the correction of the kidney over time by basically increasing levels of hydrogen ions in the urine. Okay? As a consequence, it leads to an increase in serum pH over time. Metabolic alkalosis is, thank goodness, infrequent. It's usually due to prolonged vomiting with depletion of extracellular fluid as well as chloride. You can sometimes get what's called a hypochloremic metabolic alkalosis, and it's usually due from GI suctioning or excessive bicarb intake. The other things that can cause metabolic acidosis will be things like hyperaldosteronemia, where the person has excessive aldosterone secretion. This increases your sodium reuptake, but also begins to waste your hydrogen ions in the consequence, and the person begins to increase their overall bicarb concentrations. The other thing that can induce a metabolic acidosis is all diuretics, except the carbonic anhydrase inhibitors also will induce a certain degree of metabolic alkalosis. So this is the actual pathway for basically alkalosis, metabolic alkalosis. It's usually due to loss of hydrogen ions, loss of chloride, loss of fluid, or loss of potassium. Okay? If you're looking at each one of these, if you look at the loss of hydrogen ion, of course, that's simple. Why would you lose a lot of hydrogen ions in vomiting? Stomach acid, right. Okay, as soon as you vomit all that stomach acid out, the body begins to reform new acid, and as a consequence, you begin to lose more hydrogen ions in your bloodstream. This eventually leads to a metabolic alkalosis. What you do see as a consequence is the person will begin to hypoventilate, which ends up causing accumulation of CO2, which hopefully will drop the pH back into a compensatory level. Okay. If the hydrogen ion actually is moving from the intracellular space to the extracellular space, then potassium moves along with it, which induces a hypokalemia, which can cause significant arrhythmias, usually tachydysrhythmias. If the hydrogen moves from the intracellular space to the extracellular space, you can begin to see the increase of kidney excretion of hydrogen ions and increase in acidity in the urine. You also begin to cause bicarb renal absorption to increase, which leads to an alkalosis and gives sodium chloride and potassium to stop bicarb reabsorption in the kidneys. Eventually, most of the situations lead to some form of compensation, which tries to return the pH back to its normal self, either be a bicarb loss or by hydrogen ion being reuptaken. Again, you can look at this for compensatory mechanisms. The body will try to hypoventilate to let the CO2 elevate in this kind of situation. This is the reverse of the metabolic acidosis, where you normally get hyperventilation. And eventually leads to an increased hydrogen ion concentration, which then drops your pH back to normal. Okay. The kidney takes much longer. This is fairly quick. This can be seen in the OR. If you see that somebody spontaneously breathe, versus this mechanism here will take anywhere between 6 to 12 hours before you start seeing the effect. And that's it for today. So, any questions? You don't have to go into a lot of acid-base discussion right just yet. We will go into it further along when we talk about acid bases and blood gases and stuff like that. So we will get into it in different courses. Okay?